Good morning, I'm Dr. Shona Edmonds. I'm a pediatric surgeon. I'm based in Selangor, Malaysia, and I trained as a pediatric surgeon at the University of Malaya and in Ministry of Health hospitals here in Malaysia. I thank you for the opportunity given to me today to be able to share some thoughts on management of empyema thoracis in children. I think when it comes to surgical skills, there are pretty much no shortcuts, I must say, that we have to do our time in training, in public practice to just improve on not just our skill, but our visual experience and repertoire of cases that come through the public practice more than private practice. And so we should be able to tell ourselves, those of us who train as surgeons, that it's part and parcel of just improving our knowledge and our skill. Now, the transition can be pretty challenging if we find that we are leaving an institution without adequate training. And that's where we ought to be proactively looking for places outside our institution to do short courses, to just learn how different surgeons do different techniques before we actually think of embarking on solo private practice. But even having said that, once we have had enough training, or if we think that there's actually honestly never enough training, there's always more room for improvement, okay? However, if we find that we've had enough exposure to cases in our field, right, in the public sector, and we are now at a level or a threshold where we would like to embark to go private, we have to buffer ourselves with colleagues who will be able to continue to mentor us, to train us, to help us to discuss cases. So don't leave an institution on a bad note. Always have your mentors at heart. Always have colleagues whom you can depend on. And they may not be colleagues in your same field. As for me, being a pediatric surgeon, it's a very small niche group of people. I also find that in private practice, I tend to turn to the adult surgeons in various fields to also give me some fine pointers about certain things. So sometimes I speak to my cardiothoracic colleagues about how I approach a very difficult thoracic tumor, for example. Or I would speak to a vascular surgeon, an adult vascular surgeon, if I was doing a very tricky renal tumor with an intravenous IVC thrombus. What would be the best way to tackle it? So we have good working relationships with even the adult surgeons. And so these three things that I would advise young doctors who are thinking of coming out, make sure that you've got a good base of knowledge, a good base of experience. Honestly, depending on the center that you train in, and I think, depending on the center that you actually train in, you will be able to glean a sufficient amount of experience depending on where you are. A small center, not so much. A tertiary center, you will be able to see the run-of-the-mill as well as complex cases, within 1 to 3 years of training, or following your training rather. However, in a smaller center, if you're in a smaller center, you would need more time for that. Secondly, always have a mindset of wanting to learn new techniques, develop yourself, grow yourself in the areas of your interest, of your surgical interests. And finally, have good relationships with your mentors and your peers, even if they are not in the same discipline, because you do fall back on each other's thoughts, ideas, and skills. I hope that helps. So up till about 12 years ago, that was the route that most places in the world took, including Malaysia. The surgeons would train as adult surgeons first and then do a fellowship in pediatric surgery. However, that transition has been a transition to a full-blown master's in pediatric surgery. So I was one of those who trained directly as a surgeon for children, rather than going through the route of adult surgery. However, one of the requirements for this program was that I was meant I was, I had to have at least a 2 to 3 year period of working with adult surgeons or training with adult surgeons in whichever hospital in Malaysia. And so that's part and parcel of our public service as doctors in our country. So I was a surgical medical officer for at least 3 years before I joined the program. And so I would say that having trained or focused entirely on my training in pediatric surgery actually was important, because from the start, we are taught how to handle pediatric tissues compared to adult tissues. There's a different field of it altogether. There's an earlier sense of being able to have a different field of instruments and how it translates to surgery in very small babies, right, compared to in adults. I don't think the prerequisite ought to be training to operate in adults first, but certainly having some experience in adult surgery would be beneficial. I think it's very important. All of us who actually deal with children, I think naturally have that inclination to decorate our clinic setup in an environment to create an environment of childhoodness or childlikeness. I'm not a big fan of having toys in my clinic because, especially during the pandemic, I don't want hands all over the place. So I don't have toys, whereas I know many of my pediatric colleagues do have a very nice setup with toys, with books, with like a little play area just to help the child accommodate to their to their examination. And of course, their examinations as a pediatrician tends to be much longer than a surgeon. So surgeons is quite focused. We know exactly what we're going to be examining, whereas with a pediatrician, there's a lot more going on, right? You've got the assessment of development and overall well-being. So they would need a longer time for the child to acclimatize, so to speak, in their setup. Whereas I think for a pediatric surgeon, it would be very important to have a very calm office setup. I think it's also a part of the person's personality. I like plants in my office. I think it just gives a very homely vibe to the whole thing, as it would to most families, right? And so I think the other thing that I don't do is I don't use a white coat, and I think most of us have broken with tradition. We now either wear colorful scrubs or just regular clothing, so that the child is not affected when they see someone, a doctor. So I've actually got some of my notes up here that the patients end up calling me Auntie. Hello, Auntie Shona, and in actual fact, I'm not related to them, right? So they've actually got that bond, that a non-threatening bond, because when they come into the environment, it's more like, oh, I'm seeing this lady, and yeah, she seems nice. She's examining me. So I think what you're asking is whether this setup is conducive in helping put parents and children at peace. And I think for most of us who deal with children, the answer would be yes. It's a given that our office setup is always very calming, calming for the patient and families. Yeah. Pediatric surgery has always been the truest form of general surgery left among all the subspecialties. I think adult surgeons have now become super specialized. Most of them have done things like gastrosurgery has become upper GI, lower GI, bariatric surgery. So we are truly the last of the Mohicans when it comes to pediatric surgeons. We do everything from top to toe, right? But yeah, having said that, I do think that the thrust forward would be in pediatric transplant surgery. Transplant surgery is going to be is taking off in a big way, and as it ought to. It is timely, both in and to me, it's more of liver transplant and bowel transplant. We don't have bowel transplant in my country, and liver transplant it took off, and now it's been resumed. So we're hopeful for that. So I do think there's that area it should be heavily focused on, because we have got a whole group of children who would need some form of transplant moving forward, and there's just not enough transplant surgeons. These transplant surgeons should be fully focused on purely transplant work and not general work, because it is a very heavy subspecialty in and of itself. I think another area that is very niche and growing would be in the area of tissue engineering in pediatric surgery. And really, we do need more pediatric surgeons who are also very research inclined or lab inclined to do this. Unfortunately, many of us are truly hands-on surgeons. We're very clinical. It's very hard to get us from the operating theatre to the lab, but it's not impossible, and it just depends on the individual's interest. So this would be another big area that should be looked into going forward, tissue engineering in pediatric surgery. Yeah. If not a doctor, I would have been a teacher. Yeah, that would have been yeah. I still teach my kids at home. I drive them mad, but yeah, I think I would have been quite an all right teacher. Certainly. Thank you for this time.